I'm really excited for this morning, and I'm going to turn the virtual podium over to Dr. James Wykowski, who's going to teach us about AFib. So take it away, James.
Cool. Good morning, everyone. I hope today there's a fair amount of participation, so I'd encourage you to be active in the chat and answering polls so we can have a good conversation. I picked AFib for my topic because I think we've, at some point in medical school or residency, all been shown a chart like this for how to manage AFib. And I think I had this in my mind, and then when you sit down at your computer to put in orders or understand what you're actually supposed to do next, this is rarely helpful when you're actually trying to figure out what your sort of next steps would be. And then I think on the flip side, this is often how we're taught AFib by like your cardiology attending. They just sort of say like, well, this is what I want to do now, or like, this is what we're going to do here. It's not always most helpful for developing an actual like framework for how to approach things systematically. And so I'm calling this talk kind of AFib 2.0, trying to go back through some of what our conventional wisdom around how to manage AFib and understand what the evidence behind that is, maybe generate some of our own hot takes for ourselves to take forward, then also to review some of the hot papers that have come out in the last year or so that might influence the direction of how we think about AFib. I have no financial disclosures, and our objectives today are really going to be to review some of the common options for pharmacotherapy and acute and chronic AFib, to think about some strategies for certain scenarios where maybe there aren't clear directions for us on how to manage someone's AFib, and then to examine some of that newer literature that will influence things in our career. I want to start by thinking about some definitions for AFib, because I think we describe people's AFib in a lot of different ways. So paroxysmal AFib is episodes that last less than 7 days. And so this is that person who, you know, is in AFib and out again, and typically it's not lasting for that long. Whereas once someone extends past 7 days, they sort of meet that mark for persistent AFib. And then once someone's been in AFib for greater than 12 months, they go from just persistent to long-standing persistent. And so hearing those definitions, which I don't think I really had firmly grasped before I started preparing for this talk, what do folks think about the definition of permanent AFib? How do you label someone with permanent AFib? Yeah, so just to call out some things in the chat I'm seeing are giving up all hope of sinus, shared decision-making, that you won't try to convert, and what a cardiologist says. Yeah, and I think those are all sort of get at it well, that like, if you look at the guidelines, it's sort of funny that really they basically say that like permanent AFib is really just a state of mind. It's like an agreement that the patient and the provider have made together that they're going to just give up, but they also can later decide they want to try again. I think they want to give themselves some room, you know, if new meds come out or new technology that might make sinus possible again. So you can be permanent, but then not be that anymore. And so I think I probably overuse the phrase permanent without having that like shared decision-making conversation that we've officially given up on sinus rhythm. But that is sort of what our technical definition is. The other sort of descriptor that gets thrown around a lot that I'm curious, what do people think this means? What does valvular AFib mean? Yeah, so primary cause of AFib is secondary to valve disease, concomitant valve disease, mitral stenosis. Yeah, so the ATC guidelines actually just focus on whether someone has mitral stenosis, a previous mitral valve repair, or a mechanical or bioprosthetic valve, and doesn't include aortic lesions that haven't been intervened on. I'll say that there's not a clear guideline as to whether TAVR is included in that, but I would imagine that we would include that in the valvular category still, since we would consider like a bioprosthetic aortic valve in the guidelines. I see Cody asking if this recently changed. This is what I saw when I was looking through the guidelines most recently, but if someone has late breaking info, let me know. Yeah, and Shanan's was saying that early DOAC trials didn't include patients with rheumatic heart disease. So yeah, I think, and this is sort of where that valvular definition, really, we're looking at mostly mild, mostly for mitral lesions and mostly for folks who have actually had a repair. And so I think we see a lot of people with some degree of aortic disease, but that typically wouldn't meet that. Can valvular be paroxysmal or persistent? Yes. So those are sort of valvular or non-valvular is sort of one decision tree, and then the timing marker is a different one. So yeah, the definition is any prosthetic valve or mitral stenosis. So mitral regurg does not count. Any mitral valve prolapse does not count. It's only mitral stenosis or repair. And so keep those definitions in mind, and we'll kind of review as we go through these cases today. So this is our first case, EM versus IM. This is a 65-year-old man with hypertension, HFpEF, COPD, and moderate AS coming in with new AFib. His rates are in the 130s to 140s, but otherwise he looks pretty well, talking in full sentences. And so first, what would we call his AFib, knowing this? You can unmute yourself or put it in the chat. Hemodynamically stable AFib with RVR, that's great. And then thinking about those definitions that we just talked about, would we call this persistent? Yep, so paroxysmal. And what about valvular or non-valvular? Paroxysmal AFib, non-valvular, great. And so what would we do to manage this person? This isn't a poll question, just because I think most of us as internists have the same gut reflex that like we grab from metoprolol because that's what we've been taught. And so I would give this person metope IV times 5 milligrams up to 3 doses. I'd probably pause and check blood pressures between each dose to make sure that they weren't bottoming out. Equivalent tartrate dose, keep them on short acting. And then once we'd found a stable PO dose, would convert that total tartrate daily dose to a single succinate dose. Maybe I would split it into Q12 if I was feeling esoteric or my cards attending was feeling esoteric, since some people have that practice pattern too. I think this is what I have most firmly been taught to do in most cases, and it's not wrong. We're going to expand on it today, but like I just want to hammer home that like this is the approach we're taught, and that there's good reason for it. I'm not going to spend too much more time on metope though, just because I think it's what we're most all familiar with. So instead, I want you to imagine that you're on your Medic 1 rotation and you're listening to your neighbor staff a patient with the attending, who's an EM senior resident. Same patient, same vitals. They say instead, I gave a 0.25 mg per kg DILT bolus. Heart rate dropped a little bit, and so then I re-bolused at 0.35 mg per kg. And so Courtney, you can go ahead and launch the poll. But sort of looking at this patient, and their comorbidities, what do you think about this management strategy? Is that exactly what you would have done? Is it maybe not would have been your first choice, but you're okay with it? Do you think it was probably really the wrong choice, or do you think it's like absolutely unsafe and absolutely should have done something else? Yeah, so I think most of us would fall somewhere in kind of the 2 to 3 range, maybe 4 if you were feeling really shady, that this is probably not our practice pattern. Maybe it's okay, maybe it's not. And so I think it's helpful just to sort of review why not DILT. So we know that calcium channel blockers are negative inotropes and depress LV contractility, and they carry this risk of precipitating cardiogenic shock. And I think we've probably all heard this from someone who's seen this happen before and kind of pressed this risk into our brains. That's the sort of teaching around that is really with systolic heart failure, not necessarily someone with diastolic heart failure. Although it's notable that originally when DILT was approved in the original trials for most of the calcium channel blockers, this was only based on symptoms because diastolic heart failure wasn't really like a known entity at that point. And so the original trials were based on symptoms, either class 3 or class 4 heart failure symptoms. That's symptoms at rest or with minimal exertion, less than what's typically needed to do your ADLs. And so that might be a different way to kind of screen folks to whether or not it's safe to give them diltiazem or not. There's also sort of a concern that both beta blockers and calcium channel blockers will cause some hypotension, usually more so with IV, and that this is a bigger effect with diltiazem. And so with that patient who's maybe systolics of like 91 over 50 and a heart rate of 140, who you're nervous about potentially dropping them a little bit more, you might think metoprolol is safer. There's not a ton of data around this, but there was a trial this year that went back and or I guess it wasn't a trial, it was a retrospective study that looked at sort of changes in blood pressure after giving either IV metoprolol or diltiazem, and found no significant difference in systolic blood pressure, both at 5, 15, and 30 minutes after the doses. I think it's also helpful when we're sort of examining a practice pattern that's different than ours to think about why might the ED prefer doing this? And so if you have any ideas, you can either put them in the chat or unmute yourself. What have you seen on your rotations in the ER? What do you think about sort of why they might reach for this first? Yep, so yeah, I can see you can go to the drip. If the push fails, they like the drip, longer lasting effect. Easily titratable. Medic 1 only has DILT. Yep, that's definitely true. I remember as Medic 1 doc this year, I like tried to talk the medics into using metoprolol and they were like, no, we don't have it. So some other ideas I came up with, I think there's also a perception that it works faster. And this is also borne out on a small cohort that showed it takes about on average 30 minutes to rate control with IV metoprolol and 15 with diltiazem, which isn't a major difference, but when you're in a busy ED and trying to dispo people and get folks out of there, that can be a big difference. And then there's that definitive management option where you can get someone on the drip and sort of have a plan for them straight away. And so I think my big takeaways from that are that I still plan to use metoprolol as first-line therapy in most cases, and that it is still important to be wary of diltiazem and that like we were warned about this for good reason, but to know that it is safe to use for most cases with heart failure with preserved EF, and that their ACC guidelines actually support that use, that there's not a major difference in blood pressure effects, but really just that like when we're practicing in different places, there's different pressures and controls, and so there's different practice patterns, and that's okay. So let's take this patient a little bit more and imagine that you're now the ward senior who's called to admit this person. And so they have gotten their 2 boluses and their rates are now controlled. And you're thinking about how you're going to manage this once they're on the floor. What's going to be your next move for them? Are there any situations when DILT would be favored? You know, I think it's certainly if someone's already on PO diltiazem and it works for them, most cardiologists will say to sort of use the same drug that they're already on. And then there's also a theoretical risk, more so with beta blockers with folks with reactive airway disease, that they might respond better to the diltiazem because they're not getting that beta blockade that theoretically could cause bronchoconstriction. That being said, I see and take care of a lot of folks with COPD who are on beta blockers and do okay. And so I think it's mostly sort of provider choice. And the guidelines do say with folks with obstructive lung disease to consider diltiazem as first line, but there's not like a clear recommendation against using metoprolol in those or any folks. Great, so some variation here, and I don't think that there's a right answer with this, but I think it's just interesting to examine like what are we all comfortable with, what feels like the safest thing to do. And so we'll kind of talk through dosing and options for each of these because I think it's helpful to be comfortable with them. I think, sorry, let me get the polls out of here. There we go. So in general, diltiazem dosing is a little bit less elegant than metoprolol dosing, which I also maybe think is why we as internists like it less, because it doesn't like fit in these nice, easy categories for us. The standard IV dose is this weight-based boluses. This comes from a very small cohort of like 80 patients that they saw this was safe in. And so I think I have a lot of ED providers and other providers will also just use sort of a fixed dose. 10 milligrams is a pretty safe low dose. And so like in frail older people, you can feel pretty comfortable giving most people 10 milligrams IV of DILT if you don't have time to sit down and calculate their weight-based dose, and even up to 20 milligrams at that point. And so some providers will even just sort of give those boluses in fixed doses as opposed to sort of doing the 2 separate doses. And then once someone is controlled on that, the classic thing is to put them on a drip and titrate that. And we can actually do DILT drips on the floor at all of our hospitals. I'm going through the guidelines. Typically, you can't be titrating the rate on the floor. So in some cases, if you can sort of convince the nurse to let you do it as a provider managed rate and just the nurse can't be the one titrating it, but oftentimes there'll be some pushback and prefer that to happen in an ICU setting. But when it's time to convert from IV to PO, there are clear guidelines to convert from someone's stable drip rate to a PO dose. There aren't though from the bolus to the PO, which I think makes it a little bit more confusing and difficult. But there's newer protocols sort of being explored and studied right now, and that have been shown to at least be safe. And they're sort of right now comparing the efficacy of just going straight to PO instead of starting someone on a drip. So you can imagine if you're putting someone on the drip for 24 hours, you're kind of going to delay the progression of their care long term. And so the sort of current recommendation out there in the literature is just to pretty much give everyone 60 milligrams Q6 to start once if they're controlled off of their bolus dosing, unless they're less than 60 kilos, and then to start at 30 Q6. And so I kind of think of this as the rule of sixes for most people. And in the same way, start with a short acting and then convert to a total daily dose of single dose of long acting. This wasn't something that I had heard of before, but I think it's helpful that it's not wrong to think about switching someone from diltiazem to PO metoprolol if that's what we're more comfortable with. There's also not clear guidelines for how to do that exactly, so we can Google it all we want, but we won't find a lot that's super helpful. And I think that this is another way to maybe feel comfortable using a different medication that we don't always use. So my overall sort of big takeaways from these cases and diltiazem in general is that it is safe in HFpEF unless someone is very symptomatic or has signs of right heart failure. So, you know, if someone has such severe HFpEF that they've developed pulmonary hypertension and then RV systolic failure, then there's the same risk of precipitating acute RV failure from getting diltiazem. That's usually not a subtle presentation, but something to be aware of. To consider just skipping the drip altogether and putting someone on PO straight away if they're rate controlled on the ED. And then to just sort of have these PO doses in your head of 60 milligrams for pretty much everyone, unless they're less than 60 kilos. And to know that I think the like weight-based dosing is hard to remember, but that 10 to 20 milligrams of IV boluses can also be a reasonable choice for rapid control. And a good dose for maybe if you're going to a rapid for someone who's already on diltiazem PO, you just want to give them a little bit more on top of that, but giving them like a 10 milligram bolus is also okay to do. Yeah, and I see John showing that DILT used to be much more commonly used on the floors and in clinics, to maybe think about dose reducing a little bit when you're adding up all of the PO tartrate or short acting dose into a single dose, just to give yourself a little bit of cushion. Before we move on from diltiazem, any other questions or thoughts about people's experience using DILT? So now we're going to move on to case 2. This is a 75-year-old woman with persistent AFib. She's been in it for more than 7 days, admitted after a ground level fall. Now it's sort of really difficult to control rates. She's on metoprolol 50 Q6. Yeah, and John, you're getting a little ahead of yourself. We'll get there. 50 Q6 continues to have rates in the 120s to 130s. mostly at rest, and she's asymptomatic. Her blood pressures are still normal. What would you do next for this person? So I see folks would think about going up on the dose of metope still some more, starting DIG, calling cards, and if you folks want to start DILT, you've become believers. What are sort of the max doses for these meds are a little bit unclear. Technically, they are approved up to metope succinate 400 daily. But the ACC guidelines actually say that 200 milligrams daily of succinate, or the equivalent total daily dose in tartrate, is about the max we should think about. And I think I've also sort of, being on service with different cardiologists, have heard them sort of say at a certain point, you stop getting more bang for your buck. And I think that threshold tends to come somewhere around 200, but it's probably provider dependent. Diltiazem, the max dose is 480, and the ACC actually agrees with going up to that dose as well. But I think with both, I think I've definitely been in a place where it feels like we've been going up, and things just still aren't being rate controlled. John, I was giving a hard time, brought up this idea of not combining. And so there's this question of like, can people be on both? I've also seen that. I've never felt comfortable starting it myself without a cardiologist telling me that it's safe to do. This was done a lot in the 80s for angina, interestingly. I think when we had worse meds, to stack IV and PO for rapid correction. Yeah, and that's definitely true, that you should give the PO right away to try and get to sustain someone's control and not wait for them to come back up. So we did this a lot in the 80s. I think when there was a lack of other good anti-anginals. But there is a concern that having both diltiazem and metoprolol or calcium channel and beta blocker on board will increase people's risk for heart block for symptomatic bradycardia. There's no clear guidelines actually recommending against it or for it in the setting of AFib specifically. Do you add the IV to the max dose or just PO? Not add, but I wouldn't consider someone's IV dose in sort of their total daily dose, because it is pretty short acting when I'm consolidating them to a single dose. Usually I'm waiting until someone's been on like 24 hours of just PO to think this is a stable dose that we can consolidate into a succinate or a long acting dose. So if someone's still needing IV, I would consider like that person's not ready for a succinate yet. And so in general, like I would avoid combining beta blockers and calcium channel blockers in the absence of a cardiology telling me that's exactly what I should do.
Oh, it is?
Yeah. I'll head up today.
And so I wanted to talk a little bit more about digoxin, because I think this is something that like we all learn in medical school as like this old timey med that comes from flowers, but we don't really use that much anymore because maybe it's not safe. A lot of the safety data is actually really conflicting, and most of it comes from post-hoc observational analyses. And so it can be really debated back and forth. The sort of best data we have maybe shows a dose-dependent and level-dependent risk of mortality. So folks who had a level less than 0.9 had no increased risk, and then in sort of a middle range had a trend but not a statistically significant increased risk of mortality. And then above 1.2 did have an increased risk of mortality. A lot of this can come from, it is a very pretty flower. A lot of this does come from the fact that it's renally cleared. And so I'm sort of led to wonder if some of that, if you have a higher level, it probably means you have some concomitant kidney disease or an acute kidney disease. And so I typically, I still wonder about that. I think the other thing that is often cited is that as opposed to beta blockers and calcium channel blockers, digoxin is vagotonic, and so it augments our existing vagal tone. So it tends to be less helpful if someone has exercise or activity-induced AFib, because their vagal tone at that point is already so low that it's not going to make a big difference. But for someone like this patient who's only having symptoms at rest, it might be helpful in them. DIG dosing, you have sort of 3 options to start someone. They can just be started on an oral maintenance dose, and then eventually they'll be therapeutic in 7 to 10 days. They can also be PO loaded or IV loaded. But I think it's important to know that even with an IV load, it's going to take about an hour for onset and at least 6 hours until peak. And so it's not something like metoprolol or diltiazem where you can sort of push it and hope that they will, immediately bring their rate down. I don't have any numbers up here because I would never order this without talking to a pharmacist first. It's very individual dependent based on someone's renal function, and typically is mostly safe when someone is in a sort of steady state of their renal function, but it is even safe to be used in ESRD just as long as it's dose adjusted. And so I think while you're waiting for your levels to come back later, sort of a first sign of toxicity to watch for is someone having junctional rhythm. So when someone becomes therapeutic, we expect them to have occasional junctional beats that shows that they're having some blockade. But if they're having persistent runs, then that's concerning that they're developing toxicity because they're having more profound block. And then this trial also came out in 2020 called the RATE AF trial. That was 40 adults with permanent AFib. So they had made that, they're in that state of mind with their cardiologist. They've agreed that we're giving up on sinus rhythm. And they were symptomatic and older. And they were randomized to either bisoprolol or digoxin. This is in the UK, so they're using bisoprolol. And actually found fewer medication adverse events with DIG than with the beta blocker, and some trend towards improvement in quality of life based on individual metrics, although their primary quality of life outcome, there was not a statistically significant difference. And they also didn't characterize the amount of renal disease in the cohort in the paper, which I think is a big consideration with whether or not digoxin is safe. But I think this is maybe some signal that I don't think of digoxin as a primary rate control drug. I usually use it as an augmenting, but maybe there is a role for it. Did they compare time below rate goal? I'm not sure offhand, but most of their primary outcomes were more about sort of symptom control and quality of life than actual rate control, but there may have been a secondary analysis. I'm not sure, Matt. I think my takeaways with DIG is that it's still, for me, while the safety evidence is still evolving, it seems most helpful as an adjunct where someone can get sort of a low dose, be in that less than 0.9 level, but still have good symptom control. But that maybe it is a reasonable alternative in folks who are having a lot of difficulty tolerating their beta blocker as a primary agent for rate control. And also just to know that dosing and toxicity is really individualized. So 2 people can get the same dose and have different levels and different amounts of toxicity at different levels. And so I usually always will talk to a pharmacist before I feel comfortable ordering it. Before I move on from DIG, any questions? Yeah, and so John's dropping some knowledge in the chat. But yeah, I think some of this is generational in terms of when folks trained and what was being done a lot. But I think I've also seen digoxin work a fair amount, and so it's made me sort of take a second look at maybe it is okay in some patients. Briefly review what we're looking for with toxicities. Yeah, so I think the earliest sign in an inpatient is that folks will have, like I said, sort of junctional escape beats, or will develop sustained sort of junctional rhythm. But there can also be visual changes. There can be, I don't know, I'm going to crowdsource a little here because I don't have all of them in my head off the top of my head. GI symptoms. Cool, thanks, Molly. Is it safe to stop digoxin where patients have been taking it? Watch electrolytes. You know, Ermias, I think what you're thinking of is more folks taking digoxin for heart failure, where it's helping to augment their cardiac output. I haven't seen anything about that for AFib specifically. And nystagmus dizziness. Great, so we're gonna move on to case 3, and I see Matt is talking about Apple Watches in the chat, or Mike is, so this is well timed. This 45-year-old went to the ED because he felt some palpitations, was diagnosed with new AFib, was cardioverted, discharged with some diltiazem, and then his Apple Watch told him 4 days ago he went back into AFib. He has no past medical history, drinks 2 to 4 drinks most nights. First of all, what would we call his AFib? Both valvular, non-valvular, or sort of about the duration? Holiday heart. He's drinking 2 to 4 drinks most nights. Yep, so paroxysmal non-valvular AFib, great. And so you're seeing him in clinic now. What's gonna be your next steps for him?
I'm going to keep it open for another 10 seconds. We have only about 50% of people voting right now.
Great, yeah, so I see sort of a mix of folks who are excited about talking about modifiable risk factors, and then either keeping on the DILT or thinking about a cards referral for this person. So alcohol use in AFib has long been shown to be sort of an association in cohort studies, but in 2020, we actually got an RCT for folks who drank 10 to 24 drinks per week, which is, I think, a pretty hefty amount, but there was a relatively low prevalence of binge drinking. So these were mostly folks who were having like 2 to 3 glasses of wine or 2 to 3 beers most nights, to either abstinence or usual care. And even in the abstinence group, folks were still drinking about 2.1 drinks per week. So most folks didn't make it all the way to 0. But there was still shown to be a delay in the recurrence of next episode of AFib and a lower overall burden of AFib. And so I think this really sort of showed some true efficacy for dropping down alcohol use. And so I think it's important to talk about in all patients, but maybe especially in this younger patient without a lot of other risk factors. I think it's also then important when we think about managing AFib to sort of revisit some of the big trials that often guide our thinking. And those are the RACE and AFFIRM trials. Both of these are the ones that sort of gave us our like moniker that rate and rhythm control are equivalent. But both of these cohorts were with older patients who were medically complicated. AFFIRM showed a trend towards mortality benefit with rate control that wasn't statistically significant. RACE showed no difference. But there was more sinus rhythm in the rhythm control group in both studies. And I think in both cases, you know, our patient who is young and doesn't have other medical problems doesn't really fit either of these cohorts. And so I think I, like as a primary care doctor, don't like referring people out and like to sort of take care of my people. And so my like impulse would be like, oh, well, like I can manage diltiazem, I'll just keep him here. But maybe there's some the more benefit this person can have based on their age. And so sending them to cardiology for consideration of rhythm control or other therapies might be a good idea. In general, younger folks, most antiarrhythmics your options are based on your comorbidities. So folks with structural heart disease are not eligible for a lot of the medications. This patient has sort of a lot of options. And then young people are also more likely to be symptomatic from their AFib. And most retrospective analyses show that people who are sort of very symptomatic in presentation are then much likely to feel better after being back in sinus rhythm. And then the other sort of question is that the long-term follow-up in these studies is usually around 5 years for most patients. So we don't know what the risk of keeping someone in AFib for 20, 30, 40 years would be. We know that over their time, their atria will dilate, and that may have some long-term effects on cardiac remodeling. And so it makes me a little nervous just to commit someone to permanent AFib and abandon all hope of sinus rhythm. So 3 strategies to consider are continuous pharmacologic rhythm control versus sort of this pill in the pocket strategy that I think culturally we don't do a lot in the UW system, but is essentially when someone is told that the first time they have symptoms to go to the ER, they get their first dose of rhythm control to help abort the rhythm while they're being monitored. And once it's shown that that's safe, they take that prescription with them. And anytime they feel symptoms, they can take either propafenone or flecainide to try and abort the rhythm, as well as early catheter ablation. There's sort of a soft recommendation in the guidelines for young athletes to consider like catheter ablation as a first line treatment for AFib for folks who are very symptomatic. I see people are already thinking ahead to what might be coming next, so that's great. I think some takeaways for AFib in younger patients are just to think about alcohol use as a risk factor with all patients to consider, among many other modifiable risk factors. That's all thinking about weight loss, diet, and then to consider earlier referral for rhythm control and ablation in these patients. So you're now seeing a 76-year-old man in clinic who was also recently discharged from Harvard Neuro with the TIA. He was found to have asymptomatic AFib during that admission and discharged on methotrexate and apixaban. What would you want to do for him?
Another 5 seconds or so, still at 50%.
So yeah, most folks are thinking to continue metoprolol on this person. A few folks want to refer to cards for rhythm control, and that's great. I don't know if that's Anna or Anna in the chat, but one of you is dropping knowledge. We're thinking on the same page. So this was a big trial that came out this year that sort of tried to mimic some of the same cohort that was in AFFIRM and RACE of a medically complex people. So either over 75 with a prior stroke or over 65 with 2 major comorbidities. And they used a composite outcome of cardiovascular death, stroke, or a heart failure or ACS admission. And the trial was actually stopped early for the efficacy of rhythm control, found that it reduced the time to one of these outcomes by about, with a hazard ratio of 0.78. And so I think this really sort of changes the game in terms of how we think about rhythm control, that these are people who classically we thought like they're not candidates for a lot of the meds, they have comorbidities. But I think, and the key thing that's pulled out here is that these were all people with early AFib. So their median time to diagnosis was 31 days at the time of being referred for starting rhythm control, although the trial allowed enrollment up to a year. And so I think this changed the way that I thought about AFib, and I think it's something to have in all of our heads, although there's been some kind of criticism and conversation subsequently of, is this benefit seen because of the time to intervention that these people were sort of immediately referred and started on treatment, or just because AFIRM came out in 2003 and things have evolved in the way that the drugs we have and the quality of ablations, and so they're just better therapy. They actually went back and did a subgroup analysis of AFIRM and found still no stroke mortality or cardiovascular difference with rate of rhythm control with sort of a new AFib group, people diagnosed within 6 months. And I think it's also notable that in the EASE-AF-NET-4 trial, I still hate that name, I wish they had something pithier. The people in the rhythm control group were given home devices to check 1 lead EKGs, and they transmitted those twice weekly and anytime they had felt symptoms. And any new AFib was a trigger for a new visit to escalate either their dosing, to change meds, or to refer them for ablation. So they were really aggressively managed, as opposed to the way that I think we typically are managing people's AFib. In AFIRM, the options for rhythm control were primarily sotalol and amiodarone, whereas in EASE-AF-NET-4, there was a lot more options, plus ablation. And so that's where I think there's this question of like, is this a really time to intervention benefit, or just the fact that we have newer, better interventions now? I think regardless, this is sort of an interesting piece of data that I don't think has fully, totally changed the way that we think about AFib yet, but I think will continue to evolve over the course of the next time in our careers. I think that my big takeaways of sort of the ongoing rate versus rhythm control debate is that there is a possible benefit for early aggressive intervention in patients, to think about CARDS referrals for early rhythm control, regardless of age, but especially in younger patients, and to like just keep my ear out to watch this space, because I think it's going to evolve over the course of the next years. Any other questions or comments about rate and rhythm control before we move on? The last thing I wanted to talk about was equity in atrial fibrillation. And the first thing to think about a little bit is cost. This is the average price of about a 30-day supply of most of these meds. Most of our rate control drugs are on generic and relatively affordable. As rhythm control drugs get newer, they get more and more expensive. And then the cost of catheter ablation is at least $20,000, depending on where you are and what area you're having it done in. And so definitely a big difference. And so knowing that, I think it's helpful to remember like who stands to benefit from the success of catheter ablation. This is going to be continued to be pushed. As recently as 2018, meta-analyses showed no benefit to catheter ablation as primary treatment over pharmacologic rhythm control. Then there was a trial published this year that showed benefit to primary catheter ablation. And of course, that trial was paid for by a company that makes a bunch of devices for catheter ablation. I think though on the flip side though, the cost of catheter ablation and some of these more expensive meds means that for patients on Medicaid or managed care plans, that in order to get them paid for, they will likely have to show that they didn't tolerate or didn't respond to multiple cheaper meds first. But if we think that the time to intervention seen in EASE-AF-NET-4 is real, that actually could provide like a big disparity as opposed to someone who's just willing to pay up front to like get their AFib ablated and get their symptoms better. And so I think the way that these interventions are going to be incorporated into our algorithms for care have a big potential to create some inequity. Yeah, if only some governing body could pay for that. And I think, you know, like the DIG bisoprolol trial we talked about before was done in the UK, where they're excited about potentially having people on cheaper, older meds, less so here. And I think, so thinking more about that framework we talked about with the EASE-AF-NET-4 trial, where people were transmitting their EKGs all the time, thinking about who has the technology to do that for us to be able to escalate if we're really going to be aggressive and use symptoms. but also to think about, we know that people of color, that women and people experiencing homelessness are more likely to have pain and other symptoms undertreated, under-recorded, and under-recognized by providers. I don't have a clear study proving we under-recognize symptoms of AFib in these same groups, but I don't think it's a big leap for any of us to make. And so I think it's something to have on all of our radar as a potential another place where equity might come up for our patients. And I think as a primary care doctor, when maybe the cardiologist is making decisions, one of my roles is to be an advocate for my patient and to say, like, you know, this person still really isn't symptomatically controlled. What can we do more for them? Because they may be more willing to listen to me than to the patient, which is unfortunate, but a reality of what we deal with. One strategy that we use to combat one piece of this equity that I don't think is certainly the whole pie is to think about, when I work with patients who are don't speak English as their primary language, I try and sort of document how they describe their symptoms as a reminder to myself, so that when I go back, if palpitations doesn't resonate with them, but fluttering or the funny feeling or whatever that is, to use that word to sort of mirror what they say might help bring up for them to make sure that you're actually capturing whether or not their symptoms are better or not. Any other thoughts on equity and AFib before we wrap up? Cool. So I think some big picture takeaways is to know that for those definitions, permanent AFib is just a state of mind. Until you've had that conversation, it's just persistent AFib. To know that diltiazem is probably safer than we think. It's still okay to be wary of it, but we can let our guard down a little bit. To think about digoxin as an adjunct for rate control for patients who are having difficulty with just either calcium channel blocker or a beta blocker. But maybe it's also an okay strategy as a primary agent. To know that the literature on rhythm control is continuing to evolve, but that this sort of classic rate and rhythm are equivalent probably doesn't hold totally true, and that keeping people in sinus rhythm more often is long-term going to be beneficial. And then this got cut off, but that, you know, equity affects all health conditions, and so being really thoughtful about how we approach people's care and listen to their symptoms, make sure that we're advocating for our patients is a big part of helping to combat that those inequities. Here are some of those references, and if folks are interested in looking at any of the trials I mentioned, I'm happy to send them around. And then, got it. And then my last note is to take my survey. I'm putting it in the chat right now. And it's for my ClinEd project. If you want more great ClinEd content like this, would love all of you to help out with that survey. So I'm going to put it in the chat, and while you go on break, take a second and do it. Thank you.
Awesome. Thank you so much, James. We'll come back at 9:55, which gives you 5 minutes for a break and 2 minutes to fill out James's survey. Or however long it takes. Sorry, James, I didn't mean to say that your survey only takes 2 minutes.
It's very short.
Okay.
It takes you like a hot minute. So